Welcome back to the deep dive. You've presented us with a monumental stack of source material today, charting the delicate and often perilous landscape of pediatric gastrointestinal and liver pathology.
It's definitely a dense area.
And this is a field where, diagnoses hinge on subtle details and the stakes couldn't be higher.
That's absolutely right. Our mission in this deep dive is to achieve true mastery. This isn't just about summarizing symptoms. It's about synthesizing the precise quantitative criteria, the diagnostic gold standards, and importantly, the management protocols that separate, the initial assessment from the elite professional analysis.
Right. We need to create a systematic, actionable framework.
Exactly.
Because the core challenge in pediatric GI, the reason this is so difficult, is that most diseases, from a benign stomach bug to a life-threatening congenital anomaly, they often start out presenting really nonspecifically.
Yeah, just vomiting, diarrhea, abdominal pain, or sometimes just failure to thrive. It can feel like an overwhelming amount of noise.
It really can.
So it demands a systematic filtering process. We have to train ourselves to look beyond the general complaint and immediately seek out patterns, chronicity, and those crucial red flags.
Things that tell you, stop, investigate now.
Precisely. We must differentiate, for instance, a functional issue rooted in behavior from, say, an organic failure like biliary atresia or Hirschsprung disease. Our entire structure today focuses on mastering those differentiators.
Okay, let's unpack this then. Let's start with what is arguably the most common complaint we encounter: vomiting. And we need to define it precisely because, especially in infants, parents frequently confuse it with mere regurgitation.
Yeah, that distinction is paramount, and it often dictates whether you treat or investigate further. Vomiting is the active, forceful, and often distressful expulsion of gastric contents, usually preceded by nausea.
Right, the kid feels sick beforehand.
Exactly. Yeah. Regurgitation, conversely, is involuntary, it's effortless, the expulsion of small, generally non-distressing amounts, and fundamentally it lacks that preceding nausea.
So it's more like a spill than a heave.
That's a good way to put it. And this is a common, benign physiological event, occurring in about 50% of 3 to 4 month old healthy infants. And critically, it typically resolves spontaneously by 1 year of age.
Okay, so if we confirm true vomiting, especially if it's persistent, the complications go far beyond just discomfort. We're talking about serious metabolic derangement.
Absolutely. Persistent, high-volume vomiting leads rapidly to dehydration. That's the obvious one. But beyond that, we see the classic severe sequelae. Hypochloremic metabolic alkalosis.
Okay, let's break that down. Loss of stomach acid.
Right. Losing hydrochloric acid and also potassium pushes the body's pH dangerously high. And alongside that, you get malnutrition and weight loss, obviously.
And we should probably mention the catastrophic, though. Thankfully, rare mechanical risks of extremely violent vomiting episodes.
Indeed. The sheer physical stress can cause a superficial mucosal tear in the distal esophagus. That's known as Mallory-Weiss syndrome, which results in GI bleeding. Far rarer and truly life-threatening is Boerhaave syndrome. That's a full-thickness rupture of the esophageal wall. So we have to respect the force involved in these expulsive events.
Definitely. So how do we classify the underlying problem based on the timeline and the pattern of the vomiting?
We generally use 3 classifications based on chronicity. Acute is short-lasting, often self-limited, and usually viral in origin.
The common stomach bug.
Pretty much. Chronic vomiting is frequent, often defined as occurring more than twice a week, but typically of lower intensity. This suggests a persistent GI etiology, maybe like GERD.
Okay.
Then the third, and this is a highly specific pattern, is cyclic vomiting syndrome, or CVS.
Right, let's detail the CVS criteria because they are very precise and, frankly, non-negotiable for the diagnosis, aren't they?
They really are. For CVS, the episodes must be stereotyped, meaning they occur with predictable symptoms and duration each time.
Like clockwork, almost.
Almost. And at a high intensity, which means 4 or more emesis events per hour. But critically, they must occur infrequently, separated by periods of complete normalcy, usually 2 weeks or more apart.
Okay, so intense bursts, then nothing.
Exactly. The official diagnostic criteria require either 5 episodes total or 3 episodes within a 6-month period, with each episode lasting between 1 hour and 10 days. This cyclic high-intensity pattern strongly points away from structural GI problems and more towards neurologic, metabolic, or maybe endocrine disturbances.
That level of detail is exactly what we need for this deep dive. Speaking of diagnostic clues, the color of the vomitus is absolutely fundamental as a triage question. Is it bilious or non-bilious?
This is potentially a life-saving anatomical clue. If the vomitus contains bile green or yellow, we know that the site of the obstruction or pathology must be located distal to the ampulla of Vater.
So past where the bile duct enters the duodenum.
Correct, meaning in the duodenum or beyond. Non-bilious vomiting suggests the problem is proximal to the ampulla, likely in the stomach or maybe the upper duodenum, and other associated clues are vital too. The presence of stale, undigested food points towards delayed gastric emptying or even a gastric outlet obstruction.
Like the stomach just isn't emptying properly.
Right. Vomiting that reliably occurs early in the morning can suggest an intracranial mass, raised pressure, or, as we just discussed, cyclic vomiting syndrome. And sometimes hypotonia or significant muscle weakness might push us towards considering a mitochondrial disorder.
Wow. Okay. This systematic approach leads us directly then to the absolute non-negotiables, the red flag symptoms that mandate immediate investigation, probably hospitalization.
These require immediate surgical or intensive care assessment, no waiting. They include the presence of blood hematemesis or bile in the vomit, any sign of severe abdominal pain, distension, or tenderness on palpation, sudden onset or sustained projectile vomiting, circulatory distress indicated by persistent tachycardia or hypotension, and neurological signs such as neck stiffness or photophobia, which could signal meningitis or increased intracranial pressure. If you see any of these, the investigation absolutely cannot wait. Hashtag 2.2, two distinct vomiting disorders.
Okay, let's focus our mastery now on two classic yet very distinct vomiting disorders. First, the most common surgical GI disorder in infants, idiopathic hypertrophic pyloric stenosis, or IHPS.
Right, IHPS. This is a hypertrophy, a thickening, and elongation of the circular muscle fibers of the pylorus, which is the valve at the stomach outlet. This creates a functionally narrow lumen.
So food can't get out easily.
Exactly. It has a significant sex predilection.
Yeah.
It's 4 to 6 times more common in boys, and it typically presents around 3 to 6 weeks of age, very rarely right at birth.
And the history is characteristic, isn't it?
It is non-bilious vomiting that becomes
Okay.
progressively more forceful, often described as projectile, over days or weeks.
And the physical findings are absolutely essential here for a high-yield clinical diagnosis. You can sometimes see it and feel it.
You can. The observant clinician looks for 2 things. First, that vigorous, visible gastric peristaltic wave moving across the upper abdomen, from left to right usually, as the stomach tries desperately to force contents through the narrowed outlet.
Like a little wave under the skin.
Exactly. Second, and most classically, is the palpable mass. In about 75 to 80% of infants, especially after the stomach is empty, maybe by the vomiting or if you refill it slightly, you can palpate a firm olive-shaped mass in the mid-epigastrium, usually just to the right of the midline.
The pyloric olive.
That's the one.
Diagnosis here is highly objective, though. It relies on strict measurements from imaging.
Correct. While the clinical picture is very suggestive, definitive diagnosis relies on ultrasound, and the ultrasound must demonstrate 2 critical measurements: a pyloric muscle thickness of at least 4 millimeters and a pylorus length of at least 16 millimeters.
4 and 16. Got it.
Yeah, the sensitivity of this method approaches 100%. Once it's confirmed, the sequence is rapid. Immediate correction of the dehydration and that metabolic alkalosis we mentioned.
Fluids first.
Always fluids first. Followed by the definitive surgical procedure, the Ramstedt pyloromyotomy.
Okay. Let's pivot back now to cyclic vomiting syndrome, which is clearly not structural, but systemic. We discussed the diagnostic criteria, but let's elaborate a bit on the underlying associations. What's thought to cause it?
Well, the association is clearly neurological. It seems strongly linked to migraines. As many as 30 to 40% of children with CVS have a strong family history of migraine headaches or even motion sickness,
Ah, interesting.
which is why it's often considered a kind of migraine equivalent in kids. Episodes are often triggered by distinct stressors, things like physical exertion, emotional stress, excitement, or even intercurrent infections.
And the onset.
They typically begin abruptly, often in the early morning hours, waking the child from sleep, and they're often accompanied by autonomic signs: pallor, lethargy, sometimes even a low-grade fever or tachycardia during the attack.
So this means management really has 2 distinct phases. You've got to stop the current attack and then try to prevent the next one.
Exactly right. To abort an acute attack, the priority is supportive care. For fluids, to correct dehydration, ensuring a dark, quiet environment to reduce stimuli, and using strong abortive antiemetics, typically ondansetron is the first choice, sometimes coupled with sedation if needed.
Okay.
For long-term prophylaxis, which is critical to improve quality of life and prevent missed school days, the drug choice is often age-dependent. Cyproheptadine is frequently the first line for children under 5 years old.
And for older kids?
Older children may benefit more from medications typically used for migraine prevention, like amitriptyline or propranolol, usually taken nightly. #TAG 2.3, gastroesophageal reflux disease, GERD.
Okay, next up, let's tackle GERD. We must continuously remind ourselves, and probably parents, of the crucial distinction between a physiological gastroesophageal reflux, or GER, and the actual disease state, GERD.
Absolutely. GER, simple reflux, is a normal daily occurrence in many infants. It's often brief and asymptomatic. GERD is reached only when the reflux causes troublesome symptoms and documented complications.
So it's about the consequences.
Precisely. While most healthy infants outgrow simple GER by the time they start walking, we worry about GER in those with persistent symptoms, poor weight gain, feeding refusal, or those with underlying risk factors like cerebral palsy, obesity, or perhaps a history of repaired esophageal atresia.
And the clinical spectrum here is so broad it can be confusing. It ranges from classic heartburn symptoms to really unusual respiratory complaints, doesn't it?
It does. Chronic cough, wheezing, stridor, recurrent pneumonia. These can all be manifestations of GER due to microaspiration or reflex bronchospasm.
And we absolutely must not forget the truly unique manifestation that serves as a massive diagnostic clue if you see it. Sandifer syndrome.
Yes, Sandifer syndrome. It's rare, but highly pathognomonic when present. It's characterized by these episodes of spasmodic torsional dystonia or opistotonic posturing, a strange arching of the back and neck movements, head tilting.
It looks quite alarming.
It does. Because it looks so dramatic, it is frequently misdiagnosed as a seizure disorder or some neurological problem. Yet it's merely the child attempting, perhaps unconsciously, to adopt a posture that minimizes the pain from the acid reflux. Recognizing Sandifer syndrome is really high-yield diagnostic knowledge.
Definitely something to keep in mind. When we evaluate GERD further, the standard 24-hour pH monitoring has limitations, particularly if the reflux isn't highly acidic, right? This is why the advanced technique is now considered superior.
That's exactly right. The standard has indeed shifted. The gold standard diagnostic tool is now the combined 24-hour multiple intraluminal impedance and pH monitoring, often just called MII-PH.
Okay, why is that so much better?
It's significantly superior to pH monitoring alone because impedance detects all 3 types of reflux acid, weakly acid, and critically non-acid reflux, regardless of the pH level.
So even if they're on acid blockers.
Precisely. Many infants might already be on acid suppressants, so they still reflux, but the reflux aid is non-acidic. Impedance detects the physical movement of fluid up the esophagus, allowing us to correlate all reflux events accurately with the patient's symptoms, like cough or apnea. This correlation is vital for deciding if further treatment or escalation is actually warranted.
Okay. And if we do proceed to endoscopy and biopsy, what specific histological clues confirm esophagitis, the inflammation?
Endoscopy itself can show visible evidence, like erosions and mucosal breaks, but the biopsies are key for confirmation, showing microscopic evidence of chronic damage and repair. Specifically, we look for elongation of the REIT pegs, which are projections of the epithelium, and basal cell layer hyperplasia, meaning thickening of the bottom layer of cells.
Signs of chronic irritation and turnover.
Exactly. While tissue confirmation is necessary for diagnosing severe GERD or complications like Barrett's esophagus, we must always remember, especially in infants presenting primarily with vomiting, to start with a barium swallow study.
Why barium first?
To rule out underlying structural or anatomical abnormalities like malrotation, pyloric stenosis, or esophageal strictures that might be mimicking GERD symptoms. You have to exclude those first.
Makes sense. Regarding management, we always start with lifestyle changes, but pharmacologically, PPIs are generally considered the agent of choice over H2 blockers. Why?
Right, lifestyle modification is the bedrock. Things like utilizing left lateral positioning during sleep, as the right lateral position actually promotes reflux, elevating the head of the bed, and dietary trials like thickening feeds or cow's milk protein allergy, CMPA is suspected. A trial of an extensively hydrolyzed formula is definitely warranted.
Okay, and the drugs?
Regarding drugs, we tend to avoid H2 receptor antagonists, like ranitidine or famotidine, for long-term use. They are severely limited by the rapid development of tachyphylaxis.
Meaning they stop working effectively quite quickly.
Exactly. Their effectiveness diminishes significantly, sometimes within days or weeks. PPIs, or proton pump inhibitors, omeprazole, lansoprazole, are superior because they are the strongest acid blockers available. They act on the final common pathway of acid secretion by irreversibly blocking the H plus K plus ATPase pump, the proton pump, in the parietal cells of the stomach.
More potent and longer lasting.
Correct. Treatment is typically a 2 to 4 week empiric trial if the symptoms are typical and mild, or perhaps 3 months if there's confirmed erosive esophagitis on endoscopy.
Okay, let's shift gears now from contents coming up to difficulty getting contents down dysphagia. Again, like with vomiting, location seems to be everything. Differentiating oropharyngeal versus esophageal dysphagia.
Absolutely. Oropharyngeal dysphagia, sometimes called transfer difficulty, relates to the initiation of swallowing, getting the food from the mouth into the upper esophagus. Symptoms here include things like drooling, choking, coughing during meals, or nasal regurgitation as food or liquid misses the esophagus entrance.
So, trouble starting the swallow.
Right. Esophageal dysphagia, on the other hand, is difficulty experienced during the peristaltic phase. Once the swallow starts, the food feels like it gets stuck somewhere on the way down the chest. This points much more towards either structural blockades within the esophagus or primary esophageal motor disorders.
Structural blockades seem fairly obvious. Things like strictures from previous injury or inflammation, maybe an ingested foreign body, or perhaps inflammatory conditions like eosinophilic esophagitis, EOE. Motor disorders sound trickier, like achalasia cardia.
Achalasia is a classic example of a primary motor disorder. Here, there's a failure of the lower esophageal sphincter, the LES, to relax properly during swallowing, combined with absent or ineffective peristalsis in the main body of the esophagus.
So the door at the bottom doesn't open and the pipe doesn't squeeze properly.
That's a good analogy. Children typically present with gradual onset dysphagia, first for solids, then maybe liquids, chronic regurgitation or vomiting, which is often mistaken for GERD initially, chest pain, and eventually failure to thrive due to poor intake.
How is achalasia diagnosed?
The barium swallow often provides a classic image. You see significant esophageal dilatation above a characteristic bird's beak, or pencil point, narrowing right at the gastroesophageal junction, where the LES is failing to relax. But esophageal manometry remains the gold standard diagnostic test.
What does manometry show?
Manometry directly measures the pressures. It confirms the absent peristalsis in the esophageal body and, crucially, demonstrates the incomplete or absent relaxation of the LES during swallowing attempts. Treatment then often requires interventions like pneumatic balloon dilatation of the LES or a surgical procedure like a Heller's cardiomyotomy to cut the muscle.
Okay, before we move on from dysphagia, we absolutely must highlight the critical protocol for managing foreign bodies stuck in the esophagus. This is an emergency.
It is a strict emergency protocol. The guideline is absolute. No foreign body should remain lodged in the esophagus for more than 24 hours. Even seemingly smooth objects, like coins, can cause significant mucosal damage, inflammation, and even pressure necrosis if left impacted for too long.
Where do they usually get stuck?
The three most common sites of impaction are fairly predictable anatomically. First, the cricopharyngeus muscle at the very top of the esophagus. Second, the mid-esophagus, compressed by the aortic arch or near the tracheal bifurcation. And third, just above the lower esophageal sphincter.
And the management.
Immediate endoscopic retrieval is mandatory, especially for any sharp objects or, critically, button batteries. Button batteries are extremely dangerous as they can cause rapid liquefaction, necrosis, and perforation within hours due to electrical current and chemical leakage. Urgent removal is key.
All right, let's tackle constipation. It's defined generally as delay or difficulty passing stools for 2 or more weeks, or maybe having 2 or fewer stools per week. The source material stresses that this is overwhelmingly functional, accounting for about 95% of cases in children. But we cannot afford to miss that crucial organic 5%.
That's the key balance. Functional constipation is essentially a behavioral cycle. It often starts with a painful bowel movement episode, perhaps due to a change in diet, low fiber, maybe being a bit sedentary. This pain leads to stool withholding behavior.
You see the child sort of tensing up, maybe dancing around.
Exactly. Parents often describe the child tightening their buttocks, rocking back and forth, or stiffening their legs, which looks like straining, but is actually an attempt to prevent the painful defecation. This withholding, of course, leads to the stool becoming larger, harder, and drier in the rectum.
Making the next bowel movement even more painful.
Precisely. Escalating the pain and fear, and thus perpetuating the cycle. The classic vicious cycle of stool withholding.
So the first absolutely non-negotiable step in management, especially if withholding has been going on for a while, is disimpaction. You have to clear out the backlog.
Absolutely critical. If a large fecal mass is palpable abdominally or visible, filling the rectum on examination, we must disimpact first. This rectal impaction leads to progressive dilation and stretching of the rectum, which unfortunately reduces the nerve sensitivity and the threshold necessary for the child to even sense the need to defecate. They lose the urge.
How is disimpaction best achieved?
Oral polyethylene glycol, or PEG, often with electrolytes, like PEG 3D350, is generally preferred over using repetitive enemas or suppositories. It tends to have better compliance, is less invasive, and avoids local trauma.
Okay.
We must remember, though, that using high-volume PEG electrolyte solution for an initial cleanout, especially in small or potentially dehydrated children, often requires hospital supervision. Sometimes it's even given via a nasogastric tube over several hours to ensure adequate intake and safety and prevent electrolyte imbalances.
Right. Once that successful disimpaction is achieved, the focus shifts to long-term maintenance to prevent it from happening again.
Exactly. Maintenance therapy focuses primarily on osmotic laxatives. PEG is again usually the most effective and safest option, or perhaps lactulose as first-line agents. These work by drawing water into the stool, keeping it soft. This needs to be combined with behavioral therapy, like scheduled toilet sitting times, and optimizing dietary fiber and fluid intake.
What about stimulant laxatives?
Stimulant laxatives, like Senna or Bisocidal, are generally reserved strictly as rescue therapy for occasional breakthrough constipation. They shouldn't be used for daily maintenance long-term if possible.
And persistence is key here, right?
Absolutely. This is a long game. Parents need thorough counseling that the maintenance medication must be used consistently, often for months, even after regular bowel movements resume. The high relapse rate, around 50%, is often attributable to premature medication withdrawal by parents who mistakenly perceive the initial problem as completely solved. The underlying withholding tendency might still be there.
Good point. Let's pivot now to the most critical organic cause of constipation we need to rule out, especially in infants. Hirschsprung disease, HD. This is a congenital lack of necessary nerve cells in the distal bowel.
Right. Hirschsprung's results from the failure of neural crest cells to migrate properly during fetal development, leading to an aganglionic segment of bowel, usually starting at the rectum and extending proximally for variable lengths. This segment lacks the ganglion cells in both the submucosal, Meissner's, and myenteric, Auerbach's, plexuses.
And without those nerves?
Without those nerves, the affected segment is tonically contracted, cannot relax, and cannot generate peristalsis. This creates a functional obstruction.
What are the classic clues in a neonate that should make you think of Hirschsprung's?
The single most classic clue is delayed passage of meconium. This is typically defined as failure to pass the first stool within the first 48 hours of life. While not all babies who delay have HD, most babies with HD do have delayed meconium passage.
Okay, what if it presents later?
Later presentation, perhaps in infancy or early childhood, involves chronic, often severe constipation, abdominal distension, poor feeding, and eventually chronic failure to thrive, FTT.
And the physical exam findings?
On physical examination, the potentially definitive finding is the empty rectum on digital rectal examination. The distal aganglionic segment is tight and empty. This might be followed by a sudden, often explosive gush of liquid stool and gas on withdrawal of the examining finger, as the finger passes through the tight segment into the dilated, stool-filled proximal bowel. That's the classic squirt sign or blast sign.
How do we confirm the HD diagnosis definitively?
We proceed systematically. A contrast enema, usually barium, can be very helpful. It typically shows the narrow aganglionic distal segment, a dilated stool-filled proximal bowel, and importantly, a transition zone between the two. A rectosigmoid ratio less than 1 on the lateral view is also suggestive.
What about manometry?
Anorectal manometry can be highly suggestive, especially in older children. It looks for the rectoanal inhibitory reflex normally. When the rectum is distended with a balloon, the internal anal sphincter should relax. In Hirschsprung's disease, this reflex is characteristically absent. The internal sphincter fails to relax upon rectal distension.
But the ultimate confirmation?
The undisputed gold standard for diagnosis remains the rectal biopsy. This involves taking suction biopsies or a full-thickness biopsy of the rectal wall to demonstrate, histologically, the complete and permanent absence of ganglionic cells in both the submucosal and myenteric plexuses. That confirms the diagnosis.
Okay, abdominal pain. This has to be the ultimate diagnostic puzzle in pediatrics. To really master it, the source material emphasizes we must understand how the body signals this pain based on the embryological origin of the different parts of the gut.
Yeah, understanding the innervation patterns is absolutely key to localization, or at least initial localization. Visceral pain, which comes from stretching or inflammation of the gut wall itself, is generally poorly localized and often felt in the midline. Pain from the foregut structures stomach, duodenum, liver, pancreas is typically felt in the epigastrium.
Upper abdomen.
Right. Pain from the midgut, the small bowel from the jejunum down to the appendix, and proximal colon is usually felt in the periumbilical region around the belly button.
Okay.
And pain originating from the hindgut structures, the distal transverse colon, descending colon, sigmoid, rectum, is generally sensed lower down in the suprapubic area.
And this understanding helps explain the classic shift in pain we see in conditions like acute appendicitis, doesn't it?
Exactly. Acute appendicitis typically starts with a dull, diffuse, visceral pain felt periumbilically because the appendix originates from the midgut embryologically. But as the inflammation progresses and the appendix swells and irritates the overlying parietal peritoneum, which is supplied by somatic nerves that allow precise localization, the pain shifts.
The somatic nerves feel it differently.
Right. This shifts the pain dramatically to become sharp, constant, and well-localized, typically over McBurney's point in the right iliac fossa, the right lower quadrant. That classic migration or shift of pain is one of the most clinically important high-yield findings suggestive of appendicitis.
Okay, let's focus now on the absolute surgical emergencies involving abdominal pain that need immediate intervention and diagnosis. Appendicitis is one. What else?
Besides appendicitis, we must immediately triage for intussusception. This is the telescoping of one segment of the bowel into the adjacent distal segment, like collapsing a telescope.
Right.
The most common type is ileocolic, where the ileum telescopes into the colon. It usually occurs in infants and young children, typically between 3 months and 6 years of age, with a peak around 6–18 months.
What causes it to telescope? Is there a trigger?
Often, in infants under 2, there isn't a specific anatomical lead point identified. It's thought that hypertrophy of Peyer's patches in the terminal ileum, maybe due to a viral infection, can act as the lead point that gets pulled into the colon. In older children, say over 2 years, we worry more about finding an actual anatomical lead point like a Meckel's diverticulum, a polyp, or even a lymphoma or lipoma.
What are the pathognomonic clinical signs for intussusception, the things that scream, this is it?
Well, the classic triad, which includes severe paroxysmal colicky abdominal pain, often causing the child to drop their legs, a palpable sausage-shaped mass, usually in the right upper quadrant, and the passage of red, current jelly stools, which is stool mixed with blood and mucus, is actually quite rare, seen in maybe only 15–20% of cases.
So we can't rely on seeing the triad.
No, but if you do see it, it's almost certainly intussusception. More commonly, the presentation is intermittent, severe pain, lethargy between episodes, maybe vomiting. Diagnosis is achieved quickly and reliably with abdominal ultrasound.
What does ultrasound show?
Ultrasound shows the characteristic donut sign or target sign in the transverse view, representing the layers of bowel wall telescoped within each other, or a pseudo-kidney sign in the longitudinal view. It's highly sensitive and specific.
And the treatment.
For stable children without signs of perforation or peritonitis, the preferred initial treatment is non-operative reduction, usually via air insufflation enema under fluoroscopic or ultrasound guidance. This is both diagnostic and therapeutic, and it's considered significantly safer than using liquid contrast like barium for reduction. Success rates are high, maybe 80–90%. If reduction fails or if the child is unstable, then surgery is required.
Okay, and the third really critical emergency is malrotation with volvulus. This sounds like a surgical catastrophe.
It absolutely is. Malrotation means the bowel failed to complete its normal 270-degree counterclockwise rotation during fetal life. This leaves the midgut suspended on an abnormally narrow mesenteric stalk, making it prone to twisting upon itself. That twist is the volvulus.
Cutting off its own blood supply.
Exactly. It leads rapidly to bowel ischemia, necrosis, and potentially death if not recognized and treated immediately. Any infant, especially a neonate, presenting with acute onset bilious vomiting requires immediate investigation to rule out malrotation with volvulus. That's an absolute rule. Bilious vomiting is a surgical emergency until proven otherwise.
How is it diagnosed?
Diagnosis typically relies on an upper GI contrast study, a barium meal follow-through, or BMFT. Normally, the duodenojejunum junction, DJ junction, where the duodenum meets the jejunum, should be located to the left of the spine, at the level of the duodenal bulb. In malrotation, it's abnormally positioned, often low and to the right. If volvulus is present, the contrast stream may abruptly spiral downwards, showing the characteristic corkscrew appearance.
And the treatment?
This demands immediate surgical intervention, an emergency laparotomy, and what's called the LADS procedure. This involves untwisting the volvulus, yes, present, dividing the abnormal Ladd's bands that can obstruct the duodenum, widening the mesenteric base, and placing the bowel in a non-rotated position, small bowel on the right, colon on the left, to minimize recurrence risk. An appendectomy is usually performed concurrently. Time is critical here. Hashtag tag 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 3.2, chronic functional abdominal pain.
Okay, so if we've confidently ruled out these surgical emergencies and other organic causes, we often land in the very common realm of chronic functional abdominal pain. The source material suggests this dominates pediatric gastroenterology clinics, making up maybe almost 75% of chronic abdominal pain complaints.
That figure sounds about right. It's incredibly common. The underlying pathophysiology here is thought to be visceral hyperalgesia, or altered gut-brain interaction.
Meaning the gut itself is structurally normal?
Yes, structurally and biochemically normal. But the child's nervous system, both the enteric nervous system in the gut and the central nervous system, has developed an altered, excessive perception of normal gut sensations, like motility or stretching. They interpret these harmless contractions or movements as painful.
And this is often linked to stress.
Almost always. This pain is very frequently linked to psychosocial stressors, anxiety about school, issues at home, sometimes even positive excitement. And the pain itself is typically centralized, diffuse, often described vaguely as being around the umbilicus, periumbilical.
So the big challenge here is, how do we confidently rule out an underlying organic cause without subjecting the child and the family to an exhausting and often expensive battery of unnecessary tests?
That's the art of it. We use the clear demarcation provided by the table 12.6 red flags mentioned in the source. If any of these warning signs are present, then further investigation is absolutely mandatory.
Let's list those red flags again for emphasis.
Okay, key red flags include pain that wakes a child from sleep, nocturnal pain, involuntary weight loss or failure to thrive, FTT, pain that is consistently localized away from the umbilicus, especially in the right upper or right lower quadrant, unexplained recurrent fever, any evidence of GI blood loss, vomiting blood, blood and stool, persistent vomiting, especially bilious, chronic severe diarrhea, significant family history of inflammatory bowel disease, IBD, arthritis, or unexplained abnormalities on examination like a mass or organomegaly.
So if none of those are present.
If those red flags are absent, and the history and physical exam are otherwise consistent with functional pain, the diagnostic yield of doing extensive investigations like endoscopy, colonoscopy, or comprehensive blood work is extremely low. The primary strategy then shifts entirely to education, reassurance, and management focused on coping strategies and addressing the underlying stressors rather than endless medical tests.
Okay. And the Rome 3rd criteria, now updated to Rome 4th, help us further classify these benign functional abdominal pain disorders into subtypes, right?
Yes. The Rome criteria provide standardized definitions. The three main subtypes relevant here are functional dyspepsia, where the pain or discomfort is centered in the upper abdomen, epigastrium, and isn't primarily relieved by defecation. Think indigestion-like symptoms.
Okay.
Then there's irritable bowel syndrome, IBS. The key feature of IBS-related pain is that it is explicitly associated with defecation, meaning it might be improved by having a bowel movement, or it's associated with a change in stool frequency, diarrhea or constipation, or stool form, hard or loose.
So the bowel habit link is key for IBS.
Absolutely. And the third main one is abdominal migraine. This involves paroxysmal episodes of intense acute periumbilical pain lasting for hours, often severe enough to interfere with normal activities. Critically, these episodes are usually associated with at least two other systemic symptoms, like anorexia, nausea, vomiting, headache, photophobia, or pallor. And there are symptom-free intervals between episodes.
Almost like CBS, but with pain as the main feature instead of vomiting.
Very similar pattern, yes, and likely related pathophysiology, often with that family history of migraines as well. Hashtag 3.3. Acute diarrhea and management protocols.
Moving now to acute diarrhea, this remains a really devastating global health issue, particularly for young children. The source notes it causes over 20% of deaths in children under 5 worldwide, with dehydration and malnutrition being the immediate lethal risks.
It's a massive killer still. The primary physiological concern is the rapid loss of fluid and electrolytes, primarily from the extracellular fluid, ECF compartment.
And we categorize the resulting dehydration based on the serum sodium level, right? Isonatremic, hypernatremic, and hypernatremic.
Correct. Isonatremic is the most common, where water and salt are lost in proportion. Hypernatremic dehydration occurs when relatively more salt is lost than water or when hypotonic fluids are given. This is particularly dangerous because the low ECF sodium concentration causes water to shift osmotically into cells, including brain cells, risk of cerebral edema, while further shrinking the circulating blood volume.
Okay, and hypernatremic dehydration presents a particularly deceptive clinical picture, doesn't it? It can look less severe than it is.
It is the great masquerader of dehydration. Because the sodium concentration in the ECF is high, it pulls water out of the tissue cells and into the ECF space. This helps maintain the volume in the interstitial space and intravascular space longer, delaying the classic signs of dehydration like poor skin turgor or sunken eyes.
So the skin might not tent properly.
Exactly. Clinically, the skin might feel abnormally thick, soggy, doughy, or even leathery, rather than showing that classic tenting when pinched. This demands a heightened index of suspicion, as a severely hypernatremic child can be dangerously volume depleted despite looking relatively okay, unless profound signs of circulatory failure like shock are already present. Correction also needs to be slower to avoid cerebral edema.
Right. Now, the cornerstone of management for acute diarrhea worldwide is oral rehydration solution, or ORS. Let's just briefly explain why this simple solution is so incredibly effective physiologically.
Its efficacy lies in exploiting basic intestinal biochemistry. Most common causes of infectious diarrhea, including rotavirus, which is the leading global cause, damage the intestinal lining. But importantly, they often leave the glucose-dependent sodium co-transport pump in the small intestine villi relatively intact.
Okay, and how does that pump work?
This pump actively transports glucose molecules from the gut lumen across the intestinal wall into the body. And crucially, for every molecule of glucose it transports, it drags along sodium ions and consequently water with it through osmosis. This is the physiological basis of ORS. Providing glucose and sodium together drives fluid absorption. Hence the critical need for glucose and sodium in the solution, often in roughly a 1.1 molar ratio.
Brilliant. And the formulation itself has been refined over the years, particularly favoring a specific lower osmolarity.
Absolutely. The original standard WHO ORS had an osmolarity of 311 millimol. However, extensive research showed this was slightly hypertonic compared to body fluids. Since 2004, the standard of care globally has shifted dramatically to the low osmolarity WHO ORS, which has a total osmolarity of 245 millimol.
Why is lower better?
By reducing the osmolarity, making it slightly hypotonic, we create a more favorable osmotic gradient for water absorption from the gut into the body. Clinical trials conclusively showed that this low osmolarity formulation significantly reduces stool output, reduces the frequency of vomiting, and importantly, reduces the need for unscheduled intravenous fluid rescue therapy compared to the older solution. It's just more effective.
Okay, let's quickly detail the three standard WHO management plans, A, B, C, used globally for classifying and treating dehydration.
Right. Plan A is for children with no signs of dehydration. Management is at home. The key messages are continue feeding, including breastfeeding, give extra fluids, and specifically give ORS after every loose stool, roughly 50-100 milliliter for young children, maybe 100-200 milliliters for older ones, and know the warning signs to seek care.
Okay, Plan B.
Plan B is for children with some dehydration, typically estimated 5-10% body weight loss, or 50-100 milliliter fluid deficit. This usually requires management in a health center or clinic setting. The goal is to give a specific volume of ORS over a defined period, typically 75 millikilogram of ORS over 4 hours. The child is reassessed frequently. If dehydration improves, they move to Plan A for maintenance. If it worsens, they escalate to Plan C. Ongoing stool losses during Plan B also need replacement, maybe 10 millikilograms of ORS per watery stool.
And Plan C is for the most severe cases.
Plan C is for severe dehydration, estimated 10% body weight loss or 100 millikilogram deficit, often with signs of shock like lethargy, weak pulse, low blood pressure. This demands immediate intravenous IV fluid resuscitation.
We need to be really specific about the Plan C IV fluid schedule, noting the critical age distinction in the timing of administration.
Yes. This is crucial. Plan C requires rapid administration of an isoconic crystallate solution, preferably Ringer's lactate, also called Hartmann's solution, with 5% dextrose added, or normal saline, 0.9% ACL if Ringer's lactate is unavailable. The total volume given initially is 100 millikilograms.
How quickly is that given?
The timing depends on age. For infants under 12 months old, this 100 milliliter is administered intravenously over 6 hours. Typically 30 milliliter in the first hour, then 70 millilograms over the next 5 hours. For children older than 12 months, it's administered more rapidly over just 3 hours. Again, 30 millilograms in the first 30 minutes, then 70 milligrams over the next 2.5 hours.
Why the difference?
Infants have less cardiovascular reserve and are more prone to fluid overload if infused too quickly. Regardless of age, the child must be reassessed constantly, especially pulse volume and mental status. If the radial pulse remains feeble after the initial rapid bolus, that initial bolus, for example, the 30 milliliter, must be repeated immediately. Once stabilized, they can often transition to ORS.
Okay. Beyond fluids, we must emphasize nutritional support and the role of zinc supplementation.
Critically important points. First, feeding should never be restricted during acute diarrhea, even in severe cases needing Kofei fluids. Early reintroduction of age-appropriate feeding actually promotes gut epithelial recovery and reduces the duration of illness. Continued breastfeeding is especially vital.
And zinc.
Yes, zinc supplementation is now a standard of care recommendation by WHO and UNICEF for treating acute diarrhea in children in developing countries. Giving 20 milligrams of elemental zinc per day for 10 to 14 days, 10 milligrams per day for infants under 6 months, has been proven in numerous trials to significantly decrease the duration and severity of the diarrhea episode and also reduce the risk of subsequent episodes in the following months.
Okay, and finally, the absolute safety warning regarding the use of antimotility agents.
We must strongly stress this. Antimotility agents like loperamide, Imodium, are strictly contraindicated in the management of acute infectious pediatric diarrhea, especially in young children.
Why are they so dangerous?
They work by reducing intestinal peristalsis. Yes, this might decrease the frequency of stools symptomatically, but it dangerously prolongs the contact time of pathogens, like invasive bacteria or toxins, with the intestinal mucosa. This increases the risk of bacterial overgrowth, systemic invasion, sepsis, and potentially life-threatening complications like toxic megacolon or paralytic ileus. The minimal symptomatic relief is absolutely not worth the significant mortality risk. They should not be used. Hashtag tag 3.4. Chronic diarrhea etiologies.
Okay, when diarrhea persists beyond 14 days, we enter the realm of chronic diarrhea. Here, we need to systematically investigate potential underlying causes like celiac disease, cow milk protein allergy, CMPA, and inflammatory bowel disease, IBD.
Right. Celiac disease, which is a permanent immune-mediated sensitivity to dietary gluten found in wheat, barley, and rye, is noted in the source as the most common cause of chronic diarrhea in children over 2 years of age in certain regions, like North India.
How is celiac disease diagnosed definitively?
Diagnosis relies on the comprehensive ESPGAN, European Society for Pediatric Gastroenterology, Hepatology, and Nutrition criteria. This typically involves, first, positive serological tests with IgA anti-tissue transglutaminase, IgA anti-TTG antibodies being highly sensitive and specific. Second, characteristic histological findings on duodenal biopsies obtained via endoscopy, specifically showing villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes. And third, an unequivocal clinical and often serological response to implementing a strict lifelong gluten-free diet, GFD.
Okay. What about cow's milk protein allergy, CMPA? The source notes this can be tricky because the presentation seems quite bifurcated.
It really does. CMPA splits broadly into 2 types based on the underlying immune mechanism. There's the immediate, IgE-mediated allergy, which causes acute symptoms like vomiting, hives, urticaria, wheezing, or even anaphylaxis, typically within minutes to 2 hours of ingesting cow's milk protein.
That sounds more like a classic allergy.
It is. Then there's the delayed, non-IgE-mediated, likely D-cell-mediated allergy. This tends to cause more indolent gastrointestinal symptoms, often presenting as chronic diarrhea, maybe with blood or mucus in the stool, allergic proctitis, vomiting, food refusal, or failure to thrive, occurring hours or even days after exposure.
How is that delayed type diagnosed?
Diagnosis of the delayed GI predominant type can be challenging. Sigmoidoscopy with rectal biopsy might show characteristic eosinophilic infiltration in the mucosa, which is suggestive. But the definitive diagnosis really relies on the elimination and challenge test. Symptoms must completely resolve when cow's milk protein is strictly eliminated from the child's or breastfeeding mother's diet, and then the symptoms must clearly recur when cow's milk protein is deliberately reintroduced under supervision.
Okay. And then there's inflammatory bowel disease, or IBD. This primarily means distinguishing between Crohn's disease and ulcerative colitis. What are the key differentiators?
We distinguish them based on several features, particularly the location and depth of inflammation. Ulcerative colitis, UC, is generally confined to the mucosal layer of the colon, is typically continuous in its distribution starting from the rectum and extending proximally, and thus primarily presents with symptoms like rectal bleeding, urgency, and bloody diarrhea.
Okay, so colon only, superficial, continuous.
Mostly, yes. Crohn's disease, CD, on the other hand, can affect any part of the GI tract, from mouth to anus, although the terminal ileum and colon are most common. The inflammation in Crohn's is characteristically transmural, affecting the full thickness of the bowel wall, and is often discontinuous, meaning there are affected segments, skip lesions, separated by areas of normal bowel.
And the presentation differs too.
Yes, because of the transmural nature and potential small bowel involvement, Crohn's frequently presents more insidiously with symptoms like abdominal pain, weight loss, perianal disease, fistulas, abscesses, and critically, growth failure or failure to thrive, FTT, especially if diagnosed during puberty. FTT can sometimes be the only presenting sign, making it a key warning sign for Crohn's in a child with GI symptoms.
How do we screen for and diagnose IBD?
Fecal calprotectin is an excellent non-invasive screening tool. It's a protein released by neutrophils, so high levels in the stool strongly indicate intestinal inflammation and warrant further investigation. Definitive diagnosis, however, requires endoscopy, upper GI, and colonoscopy with biopsies taken throughout the tract, including intubation and biopsy of the terminal ileum, to assess the pattern and histology of inflammation.
Okay, finally, for persistent diarrhea, especially after an acute infection that doesn't respond to initial steps like ORS and feeding, the source mentions a high-yield nutritional management strategy involving serial carbohydrate exclusion. Can you explain that?
Yes, this strategy is particularly relevant for post-enteritis syndrome, or persistent diarrhea, where prolonged damage to the intestinal lining after an infection can lead to severe secondary malabsorption, especially of carbohydrates, due to loss of brush border enzymes like lactase.
So the gut can't digest sugars properly.
Exactly. So we escalate nutritional therapy systematically if standard feeding isn't working. Diet A starts by addressing the most common issue, secondary lactose intolerance. This involves using a reduced lactose formula or diet.
Okay, step 1, less lactose.
Right. If the child fails to gain weight or stool frequency increases or persists after about 7 days on Diet A, we move to Diet B. This escalates to being completely lactose-free and also significantly reducing complex carbohydrates, starch. You might use a soy formula or a specific lactose-free, sucrose-free formula.
Step 2, no lactose, less starch.
Correct. If even Diet B fails, indicating very severe carbohydrate digestion and absorption failure, the final escalation is Diet C. This is essentially a monosaccharide-based diet, providing carbohydrates only as simple glucose, or using a formula based on glucose polymers that are easily broken down. Protein is provided from a purified source like egg white or chicken puree, and fat often as MCT oil. This is designed to completely bypass the need for enzymatic digestion of complex sugars and rely only on direct absorption of glucose. It's usually reserved for severe refractory cases under specialist supervision.
Okay, let's transition now to the complex world of the liver and hepatobiliary system. When we evaluate liver function through blood tests, it's crucial to understand that the different tests we order reflect different aspects of liver health, primarily hepatocellular injury versus the liver's synthetic capacity.
That's a key distinction. The aminotransferases, AST, aspartate aminotransferase, and ALT, alanine aminotransferase, are primarily markers of hepatocellular injury or inflammation. When liver cells are damaged, these enzymes leak out into the bloodstream.
Is one more specific than the other?
Yes, ALT is generally considered more specific to the liver, as AST is also found in significant amounts in other tissues like heart muscle, skeletal muscle, kidney, and red blood cells. Marked elevation of ALT and AST, often into the thousands, typically signals acute hepatitis or liver injury.
Okay, what about the cholestatic markers?
ALP, alkaline phosphatase, and GGT, gamma-glutamyl transferase, are markers primarily associated with cholestasis, meaning impaired bile flow or bile duct injury or obstruction.
Which one is more reliable for liver issues?
GGT is the superior, more specific marker for hepatobiliary disease in this context. ALP can be falsely elevated from non-liver sources, particularly bone. Rapidly growing children naturally have high bone turnover and thus high bone-derived ALP levels, which can confuse the picture. Elevated GGT alongside elevated ALP strongly points towards hepatobiliary source.
Right. Now, to assess the liver's actual function, its synthetic capacity, what tests do we look at?
Here we focus primarily on the liver's ability to produce essential proteins. The most important indicators are the prothrombin time, PT, and its standardized counterpart, the INR, International Normalized Ratio. These coagulation markers reflect the liver's immediate ability to synthesize clotting factors, 2, 7, 9, X, and X, many of which have very short half-life hours.
So they reflect acute function.
Exactly. A prolonged PT-INR, especially if the prolongation is greater than 3 seconds above the control value, or an INR above 1.5, is a rapid and sensitive indicator of acute synthetic failure or severe liver dysfunction. It's a critical marker in acute liver failure.
What about albumin?
Albumin, another protein synthesized exclusively by the liver, has a much longer half-life, around 20 days. Therefore, low albumin levels, hypoalbuminemia, are typically a marker of chronic liver disease and impaired synthetic function over a longer period. So prolonged PT unresponsive to vitamin K administration, coupled with low albumin, indicates poor long-term liver reserve and function.
Okay. And on physical examination, beyond jaundice, we look for the classic stigmata of chronic liver disease, CLD. What are those?
Yes, the classic peripheral signs signal systemic effects of long-standing liver dysfunction and portal hypertension. These include spider angiomata, small spider-like vascular lesions, especially on the upper body, palmar erythema, redness of the palms, particularly the thenar and hypothenar eminences, finger clubbing, and leukonychia, white discoloration of the nail beds like Terry's nails.
And assessing liver size itself.
We must also assess the liver size accurately by percussion or palpation to determine the liver span. It's important to remember that in pediatrics, the normal liver span varies significantly by age, so careful comparison to age-specific norms is essential. A liver that feels small, firm, shrunken, and perhaps non-palpable below the costal margin often signifies advanced, potentially post-necrotic cirrhosis, ### 4.2, jaundice and acute chronic liver failure.
When a child presents with jaundice, the very first step is to classify the underlying hyperbilirubinemia based on the type of bilirubin that's elevated.
Absolutely essential first step. We must distinguish between unconjugated hyperbilirubinemia, also called indirect hyperbilirubinemia, and conjugated hyperbilirubinemia, direct hyperbilirubinemia.
How do we tell them apart biochemically?
In unconjugated hyperbilirubinemia, the conjugated or direct bilirubin fraction is typically less than 15–20% of the total serum bilirubin. Unconjugated bilirubin is not water-soluble, so it doesn't appear in the urine, meaning the urine is typically normal in color, echoloric. This pattern is seen in conditions like hemolysis or Gilbert's syndrome.
Okay. And conjugated.
In conjugated hyperbilirubinemia, the direct fraction is significantly elevated, usually greater than 20% of the total bilirubin, or 1 mg/dL if total is low. Conjugated bilirubin is water-soluble, so it gets filtered by the kidneys and excreted in the urine, resulting in dark, tea-colored or cola-colored urine, coluria. Conjugated hyperbilirubinemia always signifies underlying hepatobiliary dysfunction and is always pathological beyond the early neonatal period. It demands urgent investigation.
Right. Let's talk about acute liver failure, ALF. This is a medical emergency with a very strict definition needed to trigger potentially life-saving protocols like transplant evaluation. What is that definition?
ALF is defined as the rapid onset of severe acute liver injury, specifically evidenced by impaired synthetic function, coagulopathy, with clinical evidence of hepatic encephalopathy in a patient who does not have pre-existing chronic liver disease.
What are the specific INR criteria?
The precise criteria are an INR of $1.05 accompanied by any clinical signs of hepatic encephalopathy, or an INR of $2, even without clinically detectable encephalopathy at that moment. Either of these, in the absence of known CLD, meets the definition of ALF.
Okay. The etiology of ALF in children is broad, isn't it? It includes viral hepatitis A, B, E are mentioned, drugs like acetaminophen or anti-tuberculosis meds, and various metabolic causes like Wilson disease or galactosemia. But the big clinical challenge often lies in spotting the subtle signs of hepatic encephalopathy in a child.
It's incredibly difficult, especially in infants and young children. Hepatic encephalopathy, HE, is graded in 4 stages in adults, but these stages are often subtle or manifest differently in kids. Early signs might just be irritability, poor feeding, lethargy, confusion, failure to focus, or perhaps the classic reversal of the sleep-wake cycle, being awake and agitated all night, then sleeping excessively during the day.
And the immediate danger of HE is?
The immediate life-threatening danger is the development of cerebral edema, leading to raised intracranial pressure, ICP. This can cause brain herniation and death. Management of ALF requires intensive care unit admission, meticulous supportive care, and specifically aggressive management of suspected or confirmed raised ICP. This includes keeping the patient's head elevated at 30 degrees, careful fluid management, and potentially using osmotic agents like IV mannitol or hypertonic saline to try and decrease cerebral edema.
Should prophylactic antibiotics be used?
Generally, routine prophylactic antimicrobials are not recommended as they can breed resistance. However, infection is a common trigger or complication, so empiric treatment should be started immediately if sepsis is suspected based on clinical signs or markers.
Okay. Regarding liver transplantation for ALF, we often hear about the King's College criteria being used in adults to predict prognosis and guide transplant decisions. But the source material notes these criteria have limitations in children. Why is that?
The King's College criteria were primarily developed and validated based on predicting outcomes for acetaminophen overdose, which is the most common cause of ALF in adults in many Western countries. However, in children, the etiology of ALF is far more diverse. We see a much higher proportion of cases driven by indeterminate causes, other viral infections like HSV, adenovirus, autoimmune hepatitis, and crucially, various inherited metabolic diseases like Wilson's, tyrosinemia, or mitochondrial disorders.
So the criteria don't fit the pediatric causes as well.
Exactly. A standardized prediction tool, based mainly on acetaminophen toxicity, is less reliable for this heterogeneous pediatric population. Therefore, the decision for urgent listing and proceeding with early transplantation in children with ALF often relies more heavily on the clinical trajectory, for e.g. worsening encephalopathy, refractory coagulopathy, the specific underlying metabolic diagnosis, some have very poor prognosis without transplants, and expert consensus at the transplant center rather than strict adherence to the King's College criteria alone. Hashtag tag 4.3, chronic liver disease and Wilson disease.
Moving on to chronic liver disease, CLD. The etiology obviously varies geographically. The source material, focusing perhaps on an Indian context, notes that Wilson disease is the most frequent metabolic cause identified, accounting for about 25% of pediatric CLD cases there. But notably, about 40% of cases remain cryptogenic, meaning the cause isn't found.
Yes, that highlights both the importance of considering metabolic disorders like Wilson's, especially in certain populations, and the significant challenge that even after extensive workup, a large proportion of childhood CLD remains idiopathic or cryptogenic. Other common causes globally include viral hepatitis, especially B and C, though B is vaccine preventable, autoimmune hepatitis, biliary diseases like biliary atresia sequae, and non-alcoholic fatty liver disease, NAFLD, which is rising rapidly with childhood obesity.
Let's focus on Wilson disease, as it's highlighted as common and treatable. This is a genetic disorder of copper metabolism.
Correct. It's an autosomal recessive disorder caused by mutations in the ATP7B gene, which leads to impaired biliary excretion of copper. This results in toxic accumulation of copper, primarily in the liver, but also in the brain, especially the basal ganglia, the cornea, kidneys, and other tissues.
How does it typically present in children?
The presentation is remarkably varied. It can manifest as acute liver failure, mimicking viral hepatitis. It can present as chronic active hepatitis or established cirrhosis with portal hypertension, or it can present with purely neurological or psychiatric symptoms, often starting in adolescence or young adulthood. These might include clumsiness, tremors, dysarthria, slurred speech, drooling, dystonia, a decline in school performance, or acute behavioral changes, depression or psychosis, which are frequently misdiagnosed initially.
So we need a high index of suspicion. How is Wilson disease diagnosed? It relies on a specific constellation findings, doesn't it?
Yes, diagnosis usually relies on combining clinical suspicion with several key laboratory and clinical findings. We look for four main things. First, low serum ceruloplasmin levels. Ceruloplasmin is the main copper-carrying protein in the blood, and it's typically low, less than 20 milli-GDL, in about 85–90% of patients with Wilson disease, though it can be normal in some cases, especially with acute liver failure.
Okay, low ceruloplasmin. What else?
Second, high urinary copper excretion. A 24-hour urine collection typically shows elevated copper excretion, usually greater than 100 micrograms per day, or 40 millisieverts in younger children. This reflects the body trying to get rid of the excess copper via the kidneys. Third is the presence of Kaiser-Fleischer, KF rings. These are characteristic brownish gold rings of copper deposition in Descemet's membrane on the inner surface of the cornea. They are best seen using a slit lamp examination by an ophthalmologist. KF rings are present in almost all patients, around 96%, with neurological Wilson disease, but may be absent in up to 50% of patients presenting with purely hepatic disease, especially younger children.
So absence doesn't rule it out if they just have liver symptoms.
Correct. And finally, the gold standard for diagnosis remains the quantitative hepatic copper estimation obtained via a liver biopsy specimen. A hepatic copper concentration of $250 micrograms per gram of dry liver weight is considered diagnostic, though the source mentions 50 millicd grains, 250 is the more widely cited threshold. Genetic testing for ATP7B mutations can also confirm the diagnosis.
And the treatment. It's lifelong and involves getting rid of the excess copper.
Yes, lifelong adherence to treatment is absolutely non-negotiable to prevent irreversible organ damage. Initial therapy, called induction or decoppering therapy, uses chelating agents that bind copper and promote its urinary excretion. The main options are D-penicillamine or trientine. Trientine is often favored nowadays, especially initially, as it generally has a better side effect profile than penicillamine, which can cause bone marrow suppression, autoimmune issues, or neurological worsening.
Okay, chelation first. What about maintenance?
For long-term maintenance therapy, once decoppering is achieved, or sometimes as initial therapy in asymptomatic patients, zinc salts, like zinc sulfate or acetate, are often a preferred option. Zinc works differently. It doesn't chelate copper. Instead, it works mainly in the intestinal cells by inducing the synthesis of a protein called metallothionein.
And metallothionein does what?
Metallothionein has a high affinity for copper. It binds dietary copper within the intestinal cells, effectively trapping it and preventing its absorption into the bloodstream. The trapped copper is then shed along with the intestinal cells during normal turnover and excreted in the feces. Zinc is generally well tolerated, effective for maintenance, and less expensive than chelators. Sometimes combination therapy is used. Liver transplantation is reserved for those presenting with ALF or decompensated cirrhosis unresponsive to medical therapy. Hashtag 4.4, portal hypertension, pH, and ascites.
Portal hypertension, pH, which is elevated pressure in the portal venous system, typically defined as a portal pressure gradient greater than 5 mmHg, or clinically significant when complications arise, usually above 10-12 mmHg, is a major complication of chronic liver disease. How is pH classified based on where the blockage is?
Right, pH results from increased resistance to portal blood flow, somewhere along the path from the gut to the heart. It's broadly classified by the location of this increased resistance. Prehepatic pH is due to blockage before the liver, most commonly extrahepatic portal venous obstruction, EHPEO, which is thrombosis or cavernous transformation of the main portal vein. The source highlights EHPVO as the commonest cause of pediatric pH in India, accounting for 50–75% of cases. The liver itself is often normal in EHPVO initially.
Okay.
Intrahepatic pH is due to increased resistance within the liver. This can be sinusoidal, like in schistosomiasis or congenital hepatic fibrosis, sinusoidal, the most common type due to cirrhosis distorting the liver architecture, or post-sinusoidal, like in sinusoidal obstruction syndrome.
And post-hepatic.
Posthepatic pH is due to obstruction after the liver, blocking hepatic venous outflow. The classic cause is Budd-Chiari syndrome, which is thrombosis of the major hepatic veins, or sometimes obstruction of the inferior vena cava.
Okay. The major clinical manifestation of significant portal hypertension is often ascites, the pathological accumulation of fluid in the peritoneal cavity. The source material explains this involves a complex pathophysiology that seems almost counterintuitive. The body activates fluid-retaining mechanisms even when it already seems to have too much fluid. Can you walk us through that?
It is a core paradox in cirrhosis physiology. Ascites results fundamentally from the underlying portal hypertension, causing profound splanchnic arterial vasodilation. The arteries supplying the intestines and spleen dilate massively.
Why do they dilate?
It's thought to be driven by local release of vasodilators like nitric oxide, triggered by the high portal pressure. This massive peripheral vasodilation in the gut circulation leads to a pooling of blood there, and consequently a reduction in the effective arterial blood volume perceived by the rest of the body, especially the kidneys.
So the kidneys think the body is dehydrated.
Exactly. The kidneys sense this perceived hypovolemia or underfilling. This triggers the activation of neurohormonal systems, primarily the renin-angiotensin-aldosterone system, RAAS, and the sympathetic nervous system, and stimulates ADH release. These systems cause the kidneys to aggressively retain sodium and water in an attempt to restore the perceived volume deficit.
But that retained fluid just leaks out.
Precisely. The retained sodium and water expand the total body fluid volume, but because of the high pressure in the portal system, portal hypertension, and often low plasma oncotic pressure due to low albumin synthesized by the failing liver, this excess fluid preferentially leaks out of the splanchnic capillaries and into the peritoneal cavity, forming ascites. The body thinks it needs more volume, but it just ends up third spacing it into the abdomen.
Wow. How do we quickly diagnose the cause of the ascites once we know it's present? Is it due to portal hypertension or something else?
The single most useful test for determining the etiology of ascites is calculating the SAG, which stands for the serum ascites albumin gradient.
How is that calculated?
It's simple subtraction. You measure the albumin concentration in the patient's serum, blood, and subtract the albumin concentration measured in the acidic fluid obtained via paracentesis, tapping the fluid. Serum albumin minus ascites albumin.
And what does the result tell us?
A high SAG, defined as a gradient of $1.01 GDL, strongly suggests, with about 97% accuracy, that the ascites is due to portal hypertension, most commonly from cirrhosis, but also seen in heart failure or Budd-Chiari. A low SAG, 1.1 GDL, suggests other causes like peritoneal carcinomatosis, tuberculosis, pancreatitis, or nephrotic syndrome.
Very useful differentiator. How is ascites due to portal hypertension managed?
Management involves two mainstays. First, strict dietary sodium restriction, usually limiting intake to 1 to 2 milliequivalents per kilogram per day, roughly 2 grams of sodium per day for adults. This is crucial because sodium retention is the primary driver. Second, diuretic therapy. The standard approach uses a combination of an aldosterone antagonist, typically spironolactone, paired with a loop diuretic, usually furosemide.
Well, both.
Spironolactone blocks the effect of aldosterone, promoting sodium excretion while conserving potassium. Furosemide blocks sodium reabsorption in the loop of Henle, causing more potent sodium and water loss but also potassium loss. Using them together, often in a ratio like 100 milligrams spironolactone to 40 milligrams furosemide, can achieve effective diuresis while trying to maintain potassium balance. Doses are adjusted based on weight loss and electrolytes. For refractory ascites, large volume paracentesis or TPS, transjugular intrahepatic portosystemic shunt, might be needed.
Okay. And we must always be vigilant for a serious complication of ascites, spontaneous bacterial peritonitis or SBP.
Absolutely. SBP is a highly dangerous, often lethal complication. It's defined as a bacterial infection of the pre-existing ascites fluid without an apparent intra-abdominal surgical source like a bowel perforation. It's thought to occur via translocation of gut bacteria across the bowel wall into the portal system or lymphatics, seeding the ascites fluid.
How is SBP diagnosed?
Diagnosis requires diagnostic paracentesis, tapping the ascites fluid and sending it for cell count, differential, gram stain, and culture. The key diagnostic criterion for SBP is an acidic fluid absolute polymorphonuclear PMN cell count of 250 cells per cubic millimeter, MM383. A positive culture confirms the diagnosis, but treatment should be started empirically based on the PMN count, as cultures are only positive in about 40–70% of cases.
And the treatment?
Immediate empiric intravenous antibiotic treatment is mandatory as soon as SBP is suspected or diagnosed based on the PMN count. Third-generation cephalosporins like cefotaxime or ceftriaxone are typically the first-line agents. Prompt treatment is crucial, as SBP carries a high mortality rate and drastically worsens the overall prognosis of the patient with cirrhosis. Albumin infusion alongside antibiotics may also improve outcomes, especially in patients with renal impairment.
Okay, we arrive now at perhaps the most time-critical topic in pediatric hepatology: neonatal cholestasis. This is defined as conjugated hyperbilirubinemia, direct bilirubin 1 milli-GDL, or 20% of total, persisting beyond the first 14 days of life. And the urgency here hinges almost entirely on ruling out or confirming biliary atresia, BA, as quickly as possible.
The time constraint is absolutely paramount. We cannot stress this enough. Biliary atresia is a progressive inflammatory obliteration of the extrahepatic bile ducts. If not treated surgically with a GHAI procedure, hepatoportotrostomy, within a very narrow window, it leads inevitably to cirrhosis, liver failure, and death, usually within the first 2 years of life.
And tragically, infants with BA are often missed initially, aren't they? Because they can look deceptively well at first.
That's the cruel irony. Infants with BA are often initially described as healthy-looking, feeding well, and gaining weight, despite being jaundiced. This contrasts sharply with infants who have cholestasis due to other causes like sepsis or metabolic disorders, like galactosemia, who are typically acutely sick, lethargic, vomiting, and failing to thrive. This healthy appearance can lead to dangerous delays in referral and diagnosis. So any jaundice persisting past 14 days, especially if associated with pale stools or dark urine, must trigger an immediate workup for cholestasis, with BA being the prime suspect to exclude urgently.
You mentioned pale stools. What's a simple clinical sign relating to stool color that provides a huge clue?
The persistent presence of pigmented, yellow, green, or brown stools strongly suggests that at least some bile is reaching the intestine, meaning the extrahepatic bile ducts are likely patent. This typically rules out biliary atresia. Conversely, if the stools are consistently acholic, meaning pale, clay-colored, or chalky white, this indicates complete obstruction of bile flow and makes BA highly likely. Parents should be specifically asked about stool color, maybe even shown a stool color chart.
Okay, let's detail the diagnostic process specifically for biliary atresia. How do we confirm it?
After initial blood work confirms conjugated hyperbilirubinemia and assesses liver function, the workup focuses on imaging and potentially tissue analysis. Ultrasound is useful mainly to exclude other structural causes like a cholestasis cyst. The HIDO scan, hepatobiliary immunodiacetic acid scan, or hepatobiliary scintigraphy, is valuable primarily for its high negative predictive value.
What does that mean?
It means that if the radioactive tracer injected intravenously is taken up by the liver and then excreted into the small intestine, visualized on the scan, this essentially rules out biliary atresia with high confidence. However, non-excretion of the tracer into the gut does not definitively confirm BA, as severe intrahepatic cholestasis from other causes can also result in poor excretion.
So ADIA can rule it out, but not necessarily rule it in. What's next?
Liver biopsy is highly accurate, around 90–95% sensitivity and specificity, in experienced hands for diagnosing BA. The characteristic histological findings include bile ductular proliferation in the portal tracts, bile plugs within ductules, and portal tract edema and fibrosis.
And if it's still unclear,
For equivocal cases, or sometimes as the primary diagnostic step depending on local expertise and resources, the definitive answer must come from an exploratory laparotomy with an intraoperative cholangiogram, IOC, or peroperative cholangiography, POC. This involves directly injecting contrast into the gallbladder, if present, or cannulating ducts under direct vision during surgery to visualize the biliary tree. If contrast does not flow into the duodenum, the diagnosis of BA is confirmed, and the surgeon proceeds immediately with the GHAI procedure.
okay. And the management of BA hinges on two critical factors: intense nutritional support and hitting that narrow surgical window for the GHAI.
Absolutely. Nutritional management is intensive and lifelong, even after a successful GHAI, because bile flow is often suboptimal, leading to fat malabsorption. These infants require significantly increased caloric intake, often 125–150% of the recommended dietary allowance, RDA, to support growth. Fat calories are primarily provided as MCT, medium-chain triglyceride oil, which can be absorbed directly into the portal circulation without needing bile salts for emulsification. An aggressive, high-dose supplementation of all fat-soluble vitamins, A, D, E, and K, is essential to prevent deficiencies. Specific doses are outlined in protocols.
And the GHAI procedure timing.
For biliary atresia, the surgical solution is the GHAI hepatoportoenterostomy. This procedure involves removing the obliterated extrahepatic bile ducts and connecting a loop of small intestine, a Roux-en-Y limb, directly to the liver capsule at the porta hepatis, hoping to drain bile from microscopic ductules there. The success of this procedure in establishing bile flow and prolonging the survival of the child's native liver is critically dependent on the age at surgery. The best long-term results are consistently achieved when the GHAI procedure is performed before 60 days of life, ideally even earlier, before 45 days. Outcomes decline significantly after 90 days. Time is liver.
What about cholestasis cysts, another cause of neonatal cholestasis?
Cholestasis cysts, which are congenital dilatations of the bile ducts, also require surgical management, but the approach is different. Treatment involves complete excision of the cyst and reconstruction of biliary drainage, usually via a Roux-en-Y hepatocogenostomy, connecting the bile duct above the cyst directly to the small intestine. This removes the risk of complications like cholangitis, pancreatitis, and malignant transformation within the cyst later in life.
Wow. This has been a truly comprehensive deep dive, a real masterclass. We've covered the entire spectrum, really focusing on how to move systematically from those frustratingly nonspecific initial complaints like vomiting or abdominal pain to applying the specific, often measurable criteria that unlock potentially life-saving diagnoses.
That was the goal.
We learned the importance of those non-negotiable metrics like IHPS requiring that 4 mm pyloric muscle thickness, the clear rationale for using the low osmolarity ORS 245 milli, the significance of calculating the SAG and knowing the threshold of $1 GDL for portal hypertensive ascites, and understanding that critical, non-negotiable timing of the GHAI procedure before 60 days for biliary atresia.
And we really focused on drilling down into the subtle differentiators too.
Yeah.
Understanding why combined impedance pH monitoring is superior to pH monitoring alone for GRD evaluation. Recognizing the deceptive clinical presentation of hypernatremic dehydration, and appreciated the crucial distinction between systemic causes of vomiting like CVS versus structural causes like IHPS. These clinical clues, these metric standards, they are absolutely essential for achieving diagnostic accuracy in a field where, as you said, failure to spot that small difference can have truly catastrophic consequences.
Absolutely. But even with all these mastery tools, these strict criteria, and decades of research, when we look back at some of the most complex chronic conditions we discussed, things like chronic liver disease, persistent diarrhea, even acute liver failure, the source material consistently, almost frustratingly, notes that a staggering 30 to 40% of cases, even after extensive investigation, are often ultimately labeled as idiopathic or cryptogenic. That means that even with the highest levels of professional analysis currently available, we're still left without a clear root cause for a massive number of these children.
That is the honest truth, and it remains the ongoing challenge in pediatric medicine, particularly in GI and hepatology. We have become masters of supportive care, of managing complications, of applying evidence-based protocols, but for a substantial population of patients, the fundamental why remains a mystery at the etiological level.
So we leave you, the deeply curious learner listening to this, with this final, perhaps provocative thought. Given that our current diagnostic toolbox, even at its most sophisticated, still leaves significant populations of children with these unknown cryptogenic etiologies, what current cutting-edge research, perhaps involving functional immunology, deep genetic sequencing, looking beyond single genes to complex interactions, may be detailed, longitudinal analysis of the gut microbiome and its metabolites, or even epigenetic factors? What research must we continue to monitor, to support, and to integrate into practice to finally close that gap and resolve these remaining enigmatic cases in pediatric GI and liver pathology? That's the challenge and the opportunity that awaits your next deep dive.